Hello, everyone, and welcome to KITE Research Rounds. It's my pleasure to introduce our speaker today, Dr. Scott Sands, who will be giving a talk titled Reduced Ventilatory Drive as a Predominant Mechanism of Events in Obstructive Sleep Apnea. Dr. Sands is an early career researcher investigating sleep apnea pathophysiology at Brigham and Women's Hospital and at Harvard Medical School. His lab develops translational methods to identify different causes of sleep apnea from routine sleep studies and performs focused physiology-based trials of novel and existing therapies for sleep apnea in selected patients. Please join me in welcoming Dr. Sands. And before I hand over to Mike, just a reminder that you can type in your question in the Q&A box in Zoom, and you can also see other people's questions and upvote them if you like. Thanks.
Sounds great. It's a pleasure to be back talking with you all. Of course, happy to answer any questions as we go. So this work is work that we've been doing with two postdoctoral fellows, Laura and Ludovico, and was funded predominantly by American Heart Association. We do have some funding from some industry sponsors. So, and I consult for a few companies on phenotyping concepts. This is our broader team. Laura, whose work I'm going to present first, and followed by some work of Ludovico looking at REM sleep apnea. But the point of this is just to say, thanks to our team, and that whatever we present, whatever we talk about here today is really the work of far more than just myself. So what I wanted to start with here is the classic model of obstructive sleep apnea. And I thought we could go in a little bit more detail about what that is and see if we really think this is still the most appropriate way of thinking about obstructive sleep apnea. So typically we think of somebody going to sleep. They lose their drive to their upper airway muscles at that time. Airflow, this person has a vulnerable upper airway. So when they lose their upper airway muscle activity, they lose flow. Then they have their neural drive to breathe. Going up, airflow is not increasing. There's a little bit of an increase in genioglossus activity, but it's not getting the patient anywhere. Still having a lot of trouble breathing. Finally, the person reaches a level of drive or effort to breathe that's no longer conducive to sleep, and they trigger an arousal, reopen their upper airway, reestablish flow momentarily, and then go back into the pattern again. All right, so this person appears to not improve their muscles enough, at least functionally, when they try harder to breathe. But there are other people that don't really look like this. And we're calling this drive-dependent OSA for the moment. It's sort of somewhere in the spectrum of obstructive and central sleep apnea, you might like to think. Still having an upper airway obstruction during each of their events, but what's causing that obstruction and what's leading to that obstruction? In this case, you can see this event here, a little bit of a loss of flow. That triggers an arousal. We have a patient who hyperventilates now, increased flow, increased ventilation. I'm going to use flow and ventilation interchangeably today. When they increase flow, or they get a little bit of extra flow from the arousal, they're going to have if you like, a hypocapnic or loss of chemical drive, and then the loss of actual diaphragm EMG signal. When they lose drive, they also lose flow, okay, when they go back to sleep. So by having greater ventilation here, they lost flow. It's more ventilatory instability phenotype of sleep apnea. They end up with more complete collapse, more severe desaturation as a consequence. And then actually when they increase their drive, they're able to get flow back even without arousal. So a different look to our classic obstructive sleep apnea. When we plot the signals on top of each other for every event that we can get hold of in the night where we had good enough data, we're doing time locking this data at 0 here. So this is a respiratory event. So then let's say that there was 100 respiratory events. This would be the average minute ventilation signal as a fraction of the average. And so a diaphragm EMG is falling. It's not falling to 0, and flow is still not the same as drive. So we've calibrated this so that if flow and drive were the same, such as they are during that period of arousal, the airway would be open, but flow is still much less than drive. So drive falls, the airway collapses more. So the peak inspiratory flow is lower, the airway is worse off. It's likely that drive falling is acting via upper airway muscle activity and leading to collapse in this person. So that's a little different to that first person I showed. And this is not a new concept. You know, people have been talking about this for a long time. This is some work, it's a figure from Onal, who worked with Lapato back in the 80s. And this was analysis leading into and out of respiratory events. So showing that genioglossus activity is related to diaphragm EMG, or proportional to when you do enough averaging. And in this group of subjects, this was recovery breaths, and this was during events, showing the diaphragm EMG and so overall drive to breathe, if you like, is common both to the pump muscles and the upper airway muscles. That's different to this person, just another classic OSA patient, but I wanted to show you the detailed signals here. Here's our flow, getting worse and worse over time. You can see flow limitation here. And respiratory drive is increasing as a result of that. In this person, we also had upper airway muscle recordings. They didn't do anything during the time course of the event, right? There was no, despite drive going up, there was no comparable increase in genioglossus activity. Flow continued to go down. And eventually they'd reach a level of drive that would trigger arousal from sleep. All right, so here's a couple of different pictures of sleep apnea. So we've been looking at these signals for a while, and we wanted to, what I'm going to present today is our asking the central question, which model of OSA, this drive dependent versus classic model of obstructive sleep apnea, is best supported by our physiological measurements. And so we had a set of questions. Does drive typically fall during events, or does it rise? Conventional wisdom we expected that drive would typically rise during events. Is drive typically correlated or inversely correlated with flow? Related question, answered a little differently. We expected that we would see that drive would go up while flow would go down most of the time, and in a small subset, maybe we'd see some tight correlations. How prevalent is drive-dependent OSA? And that is defined by those who have a tightly correlated flow and drive during their events. We thought this would be the minority of patients. Is lower drive associated with upper airway compromise? And we use reduced flow to measure that, and reduced genioglossus activity overnight. So that is, if it was drive dependent, if drive dependent was dominated, we would expect to see that that lower drive would be significantly associated with falling flow, less activity during sleep, regardless of whether you're in an event or not. And then is lower drive associated with greater likelihood of being in a respiratory event at any given period of time. We also then looked at whether apneas had lower drive than hypopneas. As one might expect, if it's a classic model, you expect apneas to lead to higher drive than hypopneas, whereas if it's a drive-dependent model, a greater drop in drive would lead to greater collapse. So you would have greater loss of drive in apneas than hypopneas. And then we also looked at whether REM OSA might be explained by reduced ventilatory drive overall, rather than specific loss of drive to the pharyngeal muscles. So we're going to try and get through all of this today. We'll see how we go. I don't mind if we don't make it all. So this is work from Laura, who's working with me on this. We studied 50 patients overall with a oronasal mask flow to measure flow. Drive is our diaphragm EMG catheter I talked about before. We had muscles, electrodes inserted into the upper airway muscles, so just the genioglossus, I should say, for dilator activity. In most of these same patients, we also had esophageal pressure measurements, but that'll only be a minor focus of today. And then these patients were kind of typical of those that we see in our lab. A variety of severities of sleep apnea. We didn't include controls here because we were looking at respiratory events as a focus of our analysis. And they're predominantly obstructive events, right? mostly hypopneas, but a good share of apneas, overweight individuals, diverse backgrounds, 2-to-1 male, female, as we normally see. All right, so this is what that looks like from when we're looking at individual patients. We have our full face mask. We've got a catheter going through the mask, through the nose, swallowed, and measuring diaphragm EMG. And what that looks like before we do any analysis, we've got multiple pairs of electrodes for our diaphragm EMG, cranial, caudal. It's kind of drowned out by EKG, so we try and subtract off the EKG because we have an independent measure of that. We get a moving time average signal, and then we end up with multiple EMG signals to deal with. And we pick the one with the lowest signal to noise ratio, have a few metrics of that, and we can get an intended flow signal out of this drive signal now. All right, so we can say, okay, during the good breaths in wakefulness, where there's no flow limitation, what is the, we can turn this diaphragm EMG signal into a ventilation signal. All right, so let's get into some of the results. Question 1 was, does drive typically fall or rise during events? We've got another patient with a classic OSA look over here, another patient with a drive-dependent OSA look on the right. Now, to estimate the fall in flow and drive, we need to pick some times. So we've got a baseline. A baseline for flow is quite easy, relatively easy. We can pick a time where ventilation is at 100% of the moving time average. That's a sense of what is normal flow. And for drive, we can pick a time when flow was at that value and ask what drive was. And then we want to look at how much did flow get worse and what happened to drive during that time. And so we pick the worst 10 seconds in an event for this analysis, the worst 10 seconds of flow. And that's to be consistent with what is the definition of what an apnea and a hypopnea is in the first place, which is generally defined by that worst 10 seconds. If there's a 40-second hypopnea with a 12-second apnea in it, it's counted as an apnea generally. So we've got, in this case, a 90% drop in flow, a 170% rise in drive. And so we can actually make a couple of different measurements. We've got the loss of flow, the drive loss, which is negative. And we're going to ask how big was the drive reduction, which in this case was 188% of the drop in flow. Now, if drive fell by the same amount as flow, it would be 100%. You'd think of that as a central event. If drive didn't change at all, it would be 0%. So we get a metric of how much did drive change relative to flow in terms of its, if you like, its central nature. Over here, flow has fallen. It's sort of a waxing waning pattern, kind of like a pre-Cheyne-Stokes-ish version of obstructive sleep apnea. The flow shapes are still terrible. They're still flow-limited breaths. But drive has fallen, but it hasn't fallen as much as flow has fallen, right? So it's not a central hypopnea. In fact, when we put some numbers on it, we've got a 70% drop in flow, a 20% drop in drive. And so we'll say that drive fell by 30% of the, if you're not worried about the number, you can just say, was it a positive number, which means drive fell, and a negative number, which means drive went up, right? And so in these two patients, I've got a pretty interesting looking histogram of events in this person where there was a few drive falls, but also a lot of drive increases. In this person, we've got a predominant drive falling behavior that matches their example trace here. We look at all these events together, we have 4,700 events. And what we see is that there's a skewedness to the right here, where 73% of these events that we'd analyzed had a drop in drive rather than an increase in drive. Right. So drive typically falls even in obstructive sleep apnea, which came as a surprise to us. Now, this is in the context that these events are not central. They are clearly obstructed, and they're very obstructed most of the time. So this ratio of flow to drive says how much was their ventilation matching their target value expected based on the drive signal. So a value of 40% means that flow is only 40% of the expected flow if you were looking at the drive with the EMG. So there's a lot of very obstructed breaths, and only a small 5% or so are up here, indicating some centralness. All right. Right, so drive typically falls rather than rises, 3-to-1 ratio. So the next question was, is drive typically correlated versus inversely correlated with flow? So if a drive-dependent model was dominant, you would expect that the fall in flow would be related to, in a time sense, the fall in drive. Now, we didn't really want to do this on individual events because, drive bounces around a bit. It's a little bit of a noisy signal. So it was flow, to be honest. So to deal with this, we did ensemble averaging. So just like before, I showed you how we time locked those data at time equals 0 and looked at ventilation and drive. Then we can just focus in on the event period, which is the time between these lines here, and ask, is flow or ventilation and drive correlated? And in this case, flow goes down, drive goes up, so they're inversely correlated, as you would expect. And this one on the right, drive and flow fall and rise together. And so there is a strong correlation between flow and drive. And so we expected that this would be more common. But in fact, what we saw, and this is now the group ensemble average, where we took this patient and this patient, stacked them on top of each other, stretched the event so that they time locked at the left and the right, and looked at the average behavior of flow and drive during events. You can see that flow and drive track, right? There's a little bit of a mismatch in time here in the average person. But overall, the correlation was quite strong. This is the correlation coefficient for all of those different sub-$50 patients we had. And there are a lot of patients with very strong correlations between drive and flow. And on average, this value was 75%. So flow actually normally falls in parallel with a loss of drive during respiratory events in obstructive sleep apnea, which is a surprise to us. So then we asked how prevalent is drive-dependent OSA. So we went back to these people and scored them visually with the information we had, and said, if flow continues to fall despite drive rising, that is that there's a clear departure of drive away from flow, the nadir drive, if you like, is earlier than the flow increase, then this patient would get classic. This one gets called drive-dependent OSA formally. Drive starts rising at the same time that flow starts rising. There's no evidence that flow is doing anything independently of drive. I'm quite strict on that. So we classified patients as drive-dependent or classic. And here's some of the characteristics of those that had that correlation coefficient. The blue are the classics, the red are the drive-dependent. And overall, we ended up with 30 drive-dependent patients and 20 classic patients. And these were those two features, that correlation coefficient. We weren't using these to score them, but this just to, if you like, support our scoring of what these patients were considered. These individuals had a correlation coefficient generally over 0.5. We also looked at that ensemble average drop in drive, so that the drive-dependent also had a greater reduction in drive than the classic, as you would expect, confirming our scoring here. There were, even in this minority classic group now, there were actually only 7 people who went fully backwards. That is, 7 people who had an actual increase in drive during their events while flow was at its worst. And they had that anti-correlated flow and drive. And interestingly, it wasn't like the drive-dependent individuals had a less severe version of obstructive sleep apnea, right, than the classics. Their AHIs tend to be fairly similar, supporting this as a independent phenotype of the severity. Right. So the next question, we wanted to look at whether lower drive was associated with lower flow, lower genial glossus activity, and greater event risk overnight. So we moved away from our event analysis now and looked at all the breaths in the night. We threw out arousals. We actually kept REM separate for a separate analysis. So we're just looking at non-REM, every breath in sleep, true sleep, because we've thrown out those arousal breaths. And we do this analysis normally to get phenotypes of sleep apnea. So we've just repeated this. The analysis involves taking all of the data, looking at ventilatory drive, ranking drive into 10 bins, and drawing a graph of the median drive and the median flow. And this is also the interquartile range of flow. What we get here is we can plot, instead of against time, flow and drive against time, we get flow and drive against each other overnight. And this individual, this is the same example patient I showed before. We've got as drive goes up, flow goes down, right? This was our classic individual. We've also got respiratory event probability here. The more yellow you get, the more likely a patient is to be in a respiratory event at that level of drive. So in this person, as drive goes up, as flow goes down, drive goes up, and they end up in an event. Whereas in the drive dependent example from before, is the 10 different values of drive. And as drive goes down in this person, flow goes down, and they end up more likely to be in a respiratory event. So which is the typical behavior? Well, it turns out if we take those 10 deciles and average them all and plot them on one graph, and also look at their event probability, we end up with a forwards leaning graph. So in the average person with sleep apnea, as drive goes up, flow tends to rise, right? As drive goes down, flow falls. The airway becomes more compromised, more collapsible. And they're more likely to end up in an event at lower drive rather than higher drive. And we can do statistical analysis on this, and we can say that when drive falls, there's a loss of flow. So as for every drop from 200 to 100, for example, 100, we get a 17% loss in ventilation. And we can also do logistic regression analysis and say, what's the likelihood that you'll be in a respiratory event as you lose drive? And the odds ratio is twofold. Twice as likely to go into a respiratory event as drive goes down. And then these findings are actually concentrated in that subgroup of 60% of patients who had drive-dependent OSA. So they had a 33% drop in flow as drive goes down, and a 7-fold increase in respiratory event risk as drive goes down during the night, for whatever reason. And this is to show that this is the genioglossus muscle activity. I think I lost a label there, but also showing the same idea that genioglossus activity also falls in the average person as drive goes down. And this is reasonably well established in experimental studies, but not as clear looking at every breath across the night. So we've now established that we're now comfortable that lower drive does seem to be associated with lower flow, lower genioglossus activity, and greater event risk in the night. Are events more likely to be apneas rather than hypopneas? Well, this was a fairly straightforward thing. We thought, okay, we've done all this analysis. Why don't we look and see if apneas and hypopneas are different? We can look at either the individual events or the ensemble average events, and they tell the same story, that in hypopneas, we see a drop in drive. In apneas, we see a greater drop in drive. And there's obviously a significant difference, roughly twice as much of a reduction in drive during apneas versus hypopneas. And this is all subjects. Actually, the findings are really relatively similar in both phenotypes of sleep apnea. I'm just going to do my little time check here and see how we're going. I'm doing all right. Hoping to save a bit of time for questions. So the next question, if we really thought that falling drive was leading to upper airway compromise by lowering dilator muscle activity on average, we also thought that maybe this is responsible for why REM sleep is so much worse, why OSA is so much worse in REM than non-REM in a lot of individuals. But existing data suggested, mostly animal studies, but a little bit of human data in experimental studies. The existing notion is that there's a special loss of upper airway muscle activity that's independent of the drive to the diaphragm, the drive to breathe. Right? The thought is that you go into REM sleep. We know that you lose postural muscle activity. People think generally that genioglossus muscle activity goes with that. And is lost along with, say, chin tone, right? But the diaphragm muscle is supposed to keep going, right? So if that was true, and there was a preferential deficit in pharyngeal muscle control or pharyngeal muscle activity, if we looked at our flow plotted against drive, just as we did before, and looked at non-REM sleep here in blue, then we would see either a downward shift in REM, or we would see a flattening off of the activity in REM. That is, there's no reduced responsiveness to increasing drive, or a loss of baseline activity as that first one. Whereas if there was just a simple loss of drive, a withdrawal of drive, then the flow drive curves, their profiles to describe their sleep apnea pathophysiology, would just be shifted to the left, if you like, or they would just be on a lower position on the same curve between REM and non-REM as drive goes down. And this was our hypothesis here. We thought this was the conventional wisdom on the left here. This is the work that analysis Ludo was doing while being stuck, not being able to join us physically in the lab. All right, so here's an example in one individual of non-REM and REM and respiratory events in these two states. The non-REM data was taken about an hour after the REM data for context. And these pink lines are not respiratory events. These are actual phasic REM periods where there are the bursts of eye movements. And we developed an algorithm to detect those on a breath level, so that we could later separate out tonic versus phasic REM. We thought of phasic REM as kind of the true REM. Right, so you can see this pretty obvious obstruction flow. You've got some snoring, upset flow shapes, flattening, scooping in between the hypopnea recovery periods in non-REM. The diaphragm activity goes up quite substantially from its lower levels in response, and genioglossus activity tends to follow somewhat the dilator muscle activity, the diaphragm EMG. So DI is diaphragm EMG, GG is genioglossus dilator muscles. Then in REM though, I want you to see that the diaphragm EMG is just generally smaller overall in terms of the smallest it gets and the biggest it gets, right? And this seems to be consistent when we look at this patient and other individuals. Diaphragm EMG is generally smaller. Smaller at the max, smaller at the min, smaller at the median. And the genioglossus activity tends to go with it, right? So if you find a breath of similar magnitude and you have a look, it generally has quite high activity here in terms of diaphragm activity, moderate genioglossus activity. Find a similar breath wherever you like. Pick one here. Diaphragm activity is smaller and genioglossus activity is smaller again. So we tend to have low both. And so it looks to us like common drive to both the diaphragm and the genioglossus activity are down in REM. When we analyze this formally, this is now all of those profiles of flow versus drive for each of 25 patients that we could get enough REM data in out of the 50, plotted on top of each other. And what you can see is that we don't have there's no downward shift in the REM data here versus the non-REM data here, right? REM was not lower and it wasn't flatter. In fact, it appears to more or less track the same profile, with the exception that it possibly peaks a little bit higher up here. But generally, it doesn't look like when drive falls lower, right? So if you look at this lower edge, which is the first decile value of drive and flow, it's much lower than in non-REM. So drive falls to much lower values in REM than non-REM. And when it does fall, flow goes lower and respiratory event probability goes up. So sleep apnea is worse at that time. If we look at our genioglossus activity, our upper airway dilator muscles, they're not dropping out in REM. Right, the tonic actually, the nadir value within each breath gets a little lower, but the peak is still preserved and more or less tracks the value in non-REM if it's not slightly higher. But again, when drive goes lower, genioglossus muscle activity gets a little lower again. But if we compare everything at the same level of diaphragm EMG, for example, if one person's normal diaphragm EMG is 30 microvolts, we compare them at 30 in non-REM and REM, we don't see any difference. So there's no drive independent deficit. When we look at concentrate our analysis just on phasic REM, so throw out the tonic REM, look at what we think of as maybe real REM, we see the lowest drive in those times, right? We just never get quite the same level of drive. And we get to slightly lower levels of drive again. And this is when flow is really at its worst. And it's far more obvious that flow is lower and genioglossus activity is lower in phasic REM. So we did another analysis where we asked whether, is the actual AHI, is the higher AHI we see in REM, could it be explained by the fact that drive dips to lower levels? So here we have a simple model where we take all of that data we have, our 10 deciles of drive and flow and the event likelihood. Oh, actually, this is slightly different. We've got for each patient, we have whether they've got their REM AHI and their non-REM AHI. The non-REM AHI was on average 20 and the REM AHI was on average 30. So there's an increase in AHI and REM by 10 points, like a 50% increase. Much worse hypoxia, by the way, about 5-fold worse hypoxia in REM. But there's a 10-point increase in AHI. And then we asked, could the nadir drive for each person, by nadir drive is actually just the first centile value. We don't like to take an exact nadir. That first decile value of drive is much lower in REM. So we made a model and said, is nadir drive related to AHI regardless of non-REM or REM? And it is. There's a, as drive gets lower, AHI goes up. And then we thought we could test a mediation effect. So if we adjusted for the fact that drive falls more in REM, do we still see a exacerbation of sleep apnea in REM? And we lose that signal. So when we adjust for nadir drive, the effect of REM on AHI is lowered. So we can conclude that REM does not appear to clearly increase AHI independent of drive, of the lowered drive that we see. So in summary, the things we've seen so far today, our direct physiological measurements of flow, drive, upper airway muscle activity suggest that the drive-dependent model of OSA is what I would say unexpectedly predominant. Drive typically falls instead of rises during events. There's a 3-to-1 ratio of falling versus rising events. Drive is typically highly correlated with flow during events, an R value of 0.75 within the event period itself. Drive-dependent OSA, when we score it versus classic OSA, is highly prevalent. In fact, there was only 7 out of 50, which is whatever, 14% odd, individuals who actually had a clear increase in drive during their events. We always had lower drive was, in linear models, was associated with greater upper airway collapse, co-reduced flow, and reduced upper airway dilator muscle activity during the night. It was also associated with greater respiratory event risk overnight, noting that this analysis is all limited to non-REM sleep here. Apneas had greater loss of drive by 2-fold versus hypopneas. And there was exacerbated sleep apnea severity in REM, as you know, but this was relatively well explained by reduced drive rather than a preferential deficit in input to the hypoglossal motor nucleus, if you like, or the genioglossus activity. I think I could probably continue on there. How much time do we want to save for questions?
So far, there are 3 questions typed in the Q&A. Maybe.
Yeah, let's go to those then.
Let's go to those, and if there's time, we can have more.
Let's see. Just trying to pull that up. Q&A, good. All right, we've got one from Azadeh first. Is this actually, yeah, forwards chronological? Will drive dependent versus flow dependent is it consistent in all events in the same individual over sleep, or could the pattern change over the night for the same subject? I'd say it does potentially change a little bit over the night. Just like everything varies a little. I wanted to show this person, right? You can't see for sure that this is answering that question, but I'm going to have a go at it on this individual. Let's make it a little bigger. Will it let me go? Yes. So this person on the right with drive-dependent OSA had pretty consistent drive-dependent OSA all of the time, right? These are all separate events. Now, I know there's noise when you analyze one event, you know, and what was defined as the baseline by the algorithm, etc. And so things can look a bit different, but in general, there's a histogram, and you would be reasonably happy saying this person on average drops their drive by about 1/3. But sometimes it's bigger and sometimes it's smaller, and sometimes drive doesn't change very much, right? So things are pretty consistent in this person. On the one on the left, though, I actually remember studying this person, so it was for some of the night, they were very clearly falling apart like this, not reacting. And then later on, they had a few events where they actually did appear to have some better upper airway muscle response and had a little bit of a less, a less classic look or a more drive dependent look. But then on average, their data gave them a more, a kind of borderline value. So I think there is value, if you like, in keeping some of that information, although we define them as drive dependent or somewhere in between. You've got a continuous metric of that. We know that that could be made up of extreme cases, or it could be made up of consistent values at that throughout the night. So the one way to capture that is to say, how often were they drive dependent, as well as how drive dependent were they? If we keep those two pieces of information, we get that sense of the spread. Does that help? I don't know if you can Azadeh actually, you able to talk? Or is the audience closed out?
I think she should be able to talk. Azadeh, can you unmute and talk?
I can unmute her. I'll have to allow it manually.
That's okay. That's all right. I'll leave that for now. There's enough questions. If you can say, Azadeh, you can tell me if I did a bad job at answering your question in text, if that's helpful here. Otherwise,
no, that was great, actually. Thank you, Scott.
cool.
That was that answered my question. And yeah, because of all these variations in the histogram for the same subjects, I was wondering that if we can say that, is it an event-based thing that someone may have 20% more drive dependent and 80% flow event dependent, the same way that they may have some events which are obstructive and some events which are central. Oh no, this is a phenotype of the person, and that's consistent in all the breath for all the events. Sorry.
Exactly. Yeah. So, I mean, I think that's similar to when you see someone with, let's say somebody had 50% central and 50% obstructive events. They could have all of their events at borderline central and obstructive, right? So they could all have been 100% borderline events. And if you had a number, like we're trying to put numbers on here, that said how central they were, you might have had a consistent phenotype, right? That looks a bit like both. So the score is tipped either side the whole time, or you could have somebody who actually had half the night in very clearly obstructive and then half the night in very clearly central. And the implications would be pretty different, because you would expect that, okay, they both have a high instability and they have a severe collapsibility, because they can do both, but that might be at different times. So yeah, we don't know what to do with those individuals yet, but we're making the measurements, and hopefully that can feed into some implications for therapies later on. All right, we got here more drive dependent obstruction and site of collapse. Great question. No idea, actually. I do think, though, that some of the classic OSA have a strong NED type flow shape. Now, I'm talking jargon here, but this negative effort dependence is what we often call this, or, that flow seems to go down within a breath and comes back up again within the same breath as the negative pressure gets less. This scoopiness look of the breath, which is thought not to be tongue-based collapse. There's a little bit of evidence now building from our team and others that have attributed this to more either lateral walls, palate, or epiglottic collapse. That this tends to be, anecdotally, from my point of view, associated with the classic OSA phenotype, this flow getting worse as drive goes up across breaths. And it's intuitive, flow is worse within a breath when drive is high, or when negative pressure swings are high. And flow is worse across breaths when the global drive is elevated. So it may be that some of this classic OSA is a phenotype of non-tongue-based collapse. And then you could, but there's not a lot of evidence for that that we've put together. I think that's something we should start looking at. I think you might have been thinking in the other direction, which is that drive dependent could be associated with collapse at the base of the tongue. Perhaps if upper airway muscle activity is seen most clearly in genioglossus activity and therefore genioglossus movement, that maybe tongue-based collapse behind the back of the genioglossus, for example, is the version of sleep apnea that is more drive dependent, and that's yet to be answered. That's very helpful question for what we should look at next.
Sure, I mean, that was the direction I was thinking when I was asking the question.
Yeah, what is the
Thank you.
overlap? Yeah. We haven't done much research on the overlap between the kind of upper airway and anatomical detailed phenotyping and the event-related sleep apnea pathophysiology. So I think that would be pretty interesting. There also seems to be muscle flow shapes. We'll get into that another time. A forward-leaning flow shape that looks a little bit more like a muscle EMG signal. So there may be flow shapes that actually indicate drive dependence as well. Have we looked into comparing changes in the resistance of the upper airway during common types of hypopneas versus drive dependent? Yeah, we have a sense of resistance. One way of thinking about resistance is the ratio of flow to drive. If you like, that's a version of resistance that we like to use. It's calibrated to wakefulness. It looks at the resistance, the kind of global resistance of the whole breath rather than a certain moment in time, which is complicated. So resistance changes within a breath. But if we look at flow drive, we tend to see overall that there is a loss of conductance, or one-on resistance, as the event goes on. So let's see here. So conductance, if you like, flow over drive, where a value of 1 is the wakefulness level, and anything lower than that is a reduction in conductance from wakefulness level, represents the same as the reciprocal of resistance, right? So let's say here, even at the start of the event in this person, flow is only half of drive. So resistance is double normal, right? As drive goes down though, and the peak inspiratory flow that you can get through the airway in this person goes lower. So they're flow limited this whole time because flow is less than drive. The flow shape tells you to. So I actually prefer the peak flow as a measure of their upper airway function, but their resistance is now, well, their conductance is now roughly a quarter or a fifth of drive, right? So flow is of what it was before. So flow is about 20% of drive. So resistance is roughly 5 times higher, or if you like, the total respiratory system neuromechanical impedance is 5 times higher in the middle of that event than it was in wakefulness. So it's gone from 2-fold to 5-fold. So it's a little between doubled and tripled the compromise, if you like. And that seems to happen in the drive dependent and the classic. And so I think that's important because people have a tendency, I think, to look at what we're saying with drive going down and think we mean central events, right? I know it has a kind of more central flavor or a central nature, but it is, we are trying to explain why the upper airway is getting more obstructed here. So, so drive going down leads to reduced peak flow, greater resistance, or lowered conductance. So therefore a more compromised upper airway. Hopefully that helps. Next one, are there ways to detect, please interrupt me if I haven't answered that very well. Are there ways to detect drive dependent versus the more classic dependent events from PSG data, like what you did for phenotype detection? Yeah, so that's what we're working on now as a day. I think things we did with Dwayne with the flow limitation, we had a sense of how obstructed people were, and if you see somebody has if you like, a high level of flow limitation for their level of sleep apnea severity, then you might think they're very obstructed. But if you see that their upper airway looks pretty good by flow shape, but they had some large frequency events or deep events, then we might think that they are more drive dependent. But we haven't actually done the analysis yet that fully separates folks into these 2 bins. So that's coming up. There's a few different ideas. Hopefully, our non-invasive way of getting these plots, where we have positive and negative flow drive relationships, hopefully they help us separate drive dependent from classic. that's work we're working on now. You know, can we use our existing phenotypes? Can we use our flow limitation? Can we use event-to-event consistency metrics? You know, what can we do with that? And I think that's necessary, because otherwise this is all very interesting. Explains, I think, for me, a few things about sleep apnea that were previously very confusing. The pattern of drive or flow dependent depends on sex. That's a good question. We have some data from the only analysis we have on sex so far is an analysis we did on the MESA sleep study, the MESA cohort, 2,000 patients, or 2,000 people from the community. Roughly 1,000 of them had a AHI, 3% DSAT, or arousal over 15. And we looked at a couple of metrics, and one was from our non-invasive versions. I shall move this to the left. Back. We have versions where we estimate drive, so it's not true drive from what we've got a flow from nasal pressure, an estimated drive from a model fit to the flow, and we get these kind of curves. And what we see in men is actually they tend to be flatter, so the compensation is not as good, and they're a little lower shifted. So it suggests that possibly women may have a more drive-dependent OSA, if we believe that analysis, than men, independent of their collapsibility. We also had an interesting finding that that older folks tended to have a greater compensation as well, which, you know, after adjusting for other things related to aging, you know, medications and so forth disappeared, but there did seem to be a positive relationship there that may suggest that older people may have a more drive-dependent sleep apnea sleep apnea phenotype as well. That could just be, you know, well, we'll leave that there. Trying to figure out which drive is worse. I don't know, it might depend on what the consequences are that you're worried about. So I imagine that if you react strongly to increasing drive with increasing flow, you probably protect against hypoxemia, but as a consequence, you may end up with higher ventilatory drive overall. But you may end up with less strong arousals. I guess here you've got, at the point you reach arousal, flow is very low. You've got an abrupt change in upper airway, you know, as you reopen the airway here. We haven't done any of that analysis. It's all speculative. We don't have any answer yet as to what type is worse. And so this gets, you know, it's nice that these questions are back to back as a day, almost back to back, because we need kind of non-invasive versions of this to find out exactly which type is worse. But I think we're not far off that. Do you think the drive dependency could be a factor in the non-responder? I think so. I think if there's a couple of reasons that it would be difficult, but yeah, if you got more ventilatory control instability version of sleep apnea, then I think it would be these individuals that you might think don't do so well on oral appliance. But sometimes we're surprised and we see the opposite. You know, these guys can show that they have a functional upper airway muscle. You know, it might be that this version of sleep apnea is still harder to treat for a variety of reasons. So not proven just yet. Is there a way to know whether drive-dependent OSA is not a broader definition of CSA? I guess it is a kind of broader definition of CSA, right? So, except that we've just put OSA in there. Let me draw.
Yeah, exactly. That's the part that I have most of my question.
Yeah.
That where do we say that this event, especially when we get to the hypopneas, is a central event?
Yeah, where should we draw the line? Yeah.
It's a drive dependent event, and not the classical event as we expect.
Right, can I draw on this page? Yes. So if we draw these graphs for central sleep apnea, the central sleep apnea patient flow and drive should be the same, ideally, right? And they would get to, if they got to apnea, they would get here to 0 at least. So they would have, you can't have negative flow, but you would have drive go to 0. You know, you can have subthreshold drive, but you can't see it at the diaphragm EMG. You'd only have subthreshold brainstem drive. Can I draw a straight enough line with the mouse? Almost. Oh, lost it. All right, that looks all right. So the individual would have, with central sleep apnea, would go up and down this line, where flow and drive are one-to-one relationship all of the time. But that's actually, you know, that's pure central sleep apnea, and arguably central sleep apnea is not pure most of the time we see it in the real world. You know, when we're collaborating with colleagues trying to judge who should get into a trial of central sleep apnea or not, you know, some of them look a bit obstructed, right? But they look like this, the drive is a key player in their obstructives, in their sleep apnea, whatever you want to call it. So maybe we might see some people out here where they're a bit flow limited, but the flow limitation doesn't look like it gets much worse as they go. So as their drive goes down or their effort belts drop out, you know. And these individuals with drive dependent OSA you know, if I was going to draw a line, I don't know where you would put it. But they are way out here often, right? Where there's a clear involvement of obstruction. But, and their drive is much higher generally, right? Usually higher than normal levels. So they're still spending time at high drive and just getting back to normal drive and then going back to high drive again. But yeah, I think drive dependent sleep apnea would be an umbrella that would include drive dependent OSA and CSA. So if you had to say, you would have your kind of classic OSA, drive dependent OSA, you know, and central sleep apnea. Terrible writing from you know, on a spectrum. But the challenge is, you know, in terms of what you would see, right? But I actually don't know if a spectrum is that helpful, because you can have obstruction and high loop gain or ventilatory instability at the same time. So you can have, you know, a version of severe OSA. Let's just say that you've got, you know, collapsibility of the upper airway and ventilatory instability, right? And so at zero collapsibility and high ventilatory instability, you'd be out here as perfect CSA. And no ventilatory instability and just lots of collapsibility, you'd be just sort of clear classic OSA. But you can have both, right? You can actually be up here and have highly unstable but severely collapsible as well. And you end up with some kind of mixed obstructive sleep apnea or mixed central obstructive as well. But that wouldn't necessarily even be drive dependent. But still, if you know, in the spectrum, if you traded collapsibility for ventilatory instability, I think you would pass through drive dependent OSA. And this is a fairly big, you know, it turns out this is a fairly big area where most people actually lie in. Don't know if that helps or makes things more confusing, but hopefully that's, you know, the size of this area where so many people have a version of drive dependent OSA, I think is remarkable. Get rid of that for now. Go back to our questions. We've closed. We're going to lose our connection at 1. We got through our questions anyway.
No, but I think since we had a pretty good Q&A question and discussion period, it's 1 o'clock, so it might be, unless there are other questions from the audience, I think we might be able to close at this point, so people who have other meetings at 1 can go and attend.
Sounds great.
Thank you, Dr. Sands, and thank you, Azad, and everyone who was participating in the Q&A. We appreciate it, and thank you on behalf of the Institute. I thank our speaker.
Thanks very much for having me. It's been a pleasure.
Yeah, thank you. I think the final questions were thanking the speaker.
Oh, nice. That's great.
Okay,
Thanks again, guys. Talk to you soon.
Thank you.
Bye.
Bye.